in your recording.
Yeah. Hello, everyone. Thank you for joining us today for this webinar on World TB Day. Preparations for World TB Day, it's time to tackle tuberculosis, have gone all a little bit differently with the impact of the pandemic of COVID in the last several months. And we would like to highlight today, talk about the impact of COVID on our TB programs, on our TB activities, and on our TB patients. We've put a plan together with some really great speakers, and we're very thankful for having so many people interested. Right now we have 500 people registered for this webinar. I'd like to ask everyone who's not a speaker to turn off your videos and your speakers so that we allow our 10 speakers to have the floor properly. We have a chat function open. If you have any questions, please use the chat function. I will collect all questions and I will be moderating the questions in the end. You can also raise your hands in the chat if you're with Zoom. That means that I can see that you would like to say something. In that case, I will, after every speaker has spoken and we enter the discussion time, I will try to find a space for you to actually join the call and say something. We will be recording. It's a 1.5 hour session. Everything will be on our website. After this session, you will be able to download any of the presentations. All the questions that will be put forward today, either by email or in the chat function, will be added to our site, and we will make sure that the experts will go into the questions. We will also be producing a Q&A after this so that you have an easy reference, and we will hope in the upcoming weeks to continue the discussion with you on our TB forum. So today, speaking to us and showing their knowledge, we're really excited that we have Madhu Pai from McGill, who will be talking about the article that he wrote in the Forbes. Then joining us from China is Hairong Huang, and from South Korea, JJ Kim. They will be giving us on-the-ground experiences from dealing with the COVID and the TB co-activities. Then we will have Vidya Krishnan from India showing, talking about the situation in India and about her view, how things are going, followed by 4 people who have actually struggled with tuberculosis, and they will be giving their points of view. We will have Ingrid Schoeman from South Africa is with us, Deepti Chavan from India is with us, Kate O'Brien from the US, and Saurabh Rane. They will each give their points of views, and we'll close our session with a talk from Sahu, Suvanand, who's from the Stop TB Partnership, and he will give some comments on the global activities happening today and giving input on the damage control plans. So if I can give the floor, I will not introduce every time. If you have any questions of clarifications, please use the chat room, then I'll try to interrupt the speakers. Otherwise, we will go in a flow of speakers, and I'm asking Madhu to start, and he's showing a presentation. Thank you, Madhu. Madhu, you're on mute. I'm unmuted.
Can you see my slides?
Yes, perfectly.
Okay.
Go ahead.
Do I need to make it full screen, or is this okay?
This is okay if you're comfortable with that.
All right. Thanks everyone for joining us. This is not anything like a World TB Day I've ever seen before. I'm not my usual bouncy self. I'm anxious and I'm stressed, as I'm sure every one of you is, which is why we are all here today. So I'll dive right into it. My job is to set the stage with what little we know about COVID and TB. I'm not saying my presentation is comprehensive or complete. I'm only using it as a jump off point to have our discussion going. The real goal of this webinar is to collectively put our heads together and see what best we can do to limit the damage. As you can see from the post I wrote, which has now been read by almost 40,000 people, I'm already assuming that there is damage. I'm not even challenging for a second if there will be damage. I'm saying there is damage, And I'm saying we all need to swing into a complete damage control mode. And we need to do it right now and not wait for the pandemic to subside. If this pandemic drags on for 6 months or a year, and if we wait until everybody comes up for air and start worrying about TB, we may well see a doubling of TB mortality in a year. And we simply cannot afford that, which is why I'm asking all of us to put our heads together and start planning in whichever city, town, village, area, country we're working in. Now, even without COVID, we know what the level of damage that TB is causing, right? I'm not going to spend even a second on this, just to say that even the pre-COVID world, TB was bad all around. And now with COVID, we are looking at a potential catastrophe in the making. So this is today's data, almost 380,000 cases, 16,000 deaths. While the trajectory in some countries, which I'll show in a second, is worrisome, what making me most anxious now is that COVID is hitting high TB burden countries. And this is where the problems and challenges are going to explode. Now, before I get there, here is a very quick overview of what little we know about SARS-CoV. None of this is set in stone. Everything is changing as we speak. But we know that the SARS-CoV virus might have come from bats. We know the route of transmission is through respiratory droplets. We know the average incubation period is about 5 days. The R0, which is a spectacularly important number for epidemic modelers, is the number of additional people who will get infected from one person who has SARS-CoV-2. And that number is hovering between 2 and 3, which means each person will infect 2 to 3 additional people. And if that daisy chain continues, that is why we are seeing the explosive pattern of increase. Initially, it doesn't look bad, but the minute it hits a certain threshold, the trajectory starts rocketing upwards. That's the exponential pattern that every country is showing right now. The primary symptoms are fever and dry cough. The first line diagnostic test right now is a molecular test, just like the GeneXpert test for TB. It's a RT-PCR based assay. There is no specific treatment as of now. There is no specific vaccine as of now. Flu vaccines simply do not protect against COVID. Case fatality is extremely variable depending on the country. It could be as low as 0.5% or as high as 4%, depending on which country and which setting this is being played out in. But the high fatality is one reason why everybody is so nervous about this epidemic. One is the explosive spread and the number of people who will potentially get infected. And the fatality, even if it is a small proportion, will still mean thousands of people will die. Can you all please mute your mics, please? Petra, can you do a mute all using your control system? Thank you. And then the last thing we know is that outcomes of COVID-19 are particularly bad among older people, as well as people with pre-existing medical conditions such as hypertension, heart disease, lung disease, cancer, or diabetes. That is the group that is most likely to of COVID-19. Now, tuberculosis or HIV does not show up right now in any of the news reports as a pre-existing medical condition. But I am arguing, as you will see in a second, that we should assume that people with TB are at higher risk of dying of COVID. And that's the correct assumption to work in at this stage of the epidemic. I do not want us to think that somehow TB patients will be protected. I mean, there's already some rumors that the people with HIV are somehow protected, which I think is rubbish. And we simply cannot buy into that this stage of the epidemic. And we cannot falsely reassure people that everything is going to be fine, okay? So I'm going to assume that TB is just a pre-existing medical condition like any of the ones listed here already. Now, this is the current trajectory of the epidemic in many countries. This includes the most explosive forms of the outbreak that we are currently seeing in North America and Europe. We know that Europe today is the epicenter of the global pandemic, and US is very strongly tracking at a rate that is even worse than Italy. And you can already see there that some high TB burden countries are starting to make the list. Brazil is right there and trending like everybody else. India is on the lower side. That's because, as Vidya will tell us, India is practically testing nobody. And at this stage, that's why the numbers are not reliable from countries like India. But any country that is ramping up testing is finding more and more cases. And this, to me, is the most terrifying thing, which we did not see even a month ago. COVID-19 now is taking off in the highest TB burden countries. We already know China is a high burden country, and we know China cases are starting to finally plateau, almost 100,000. But look at the trajectory in India, Brazil, Indonesia, look at Philippines, South Africa, Nigeria, Pakistan. Every country trajectory starts resembling the same after a while. There is no country that is escaping this pandemic, and nobody has quite figured out what to do with it, with the possible exception of what China has done, Korea has done, and to some extent, there is similar data from Hong Kong, Singapore, and Japan. Other than a handful of cases, which seem to have a different trajectory, everybody else is on the same trajectory. Mute your mics, please. Can you please mute your mics? Thank you. Now, how is COVID-19 disrupting TB services? Can you please mute your mic?
And Madhu, you're unmuted again. Sorry about that.
Okay, so we will hear from a second from Hairong on how China has already seen a disruption of TB services. We will hear from JJ Yim in a second on what South Korea has seen. And I won't say much about here and let them speak in first person. I've also heard from colleagues in Italy that they're already noticing a decrease in the number of TB notifications, and non-essential services such as follow-up of TB patients have been put on hold. So that's what I've heard from Italy so far. Now, we will also hear in a few seconds about the anxieties that people with TB survivors have about this particular condition. Before we talk about mitigation strategies, I want to spend a little bit of time on the likely pathways by which COVID-19 can affect TB. Can everybody mute their microphones, please?
Keep going, Madhu.
Okay. You may have to keep doing this, Petra.
Yes, I will.
Okay. All right. So here are the likely pathways by which COVID-19 can affect TB. Some of them are confirmed. We already know that's happening. And others are, at this point, a conjecture. So firstly, as we already discussed, pre-existing lung damage is most definitely likely to make TB patients either more prone to COVID-19 or more prone to die of TB. There is very little data to support this yet, but this, I think, is a very safe assumption. And unless proven otherwise, we need to stick to this assumption. Second, comorbidities we know that TB patients often tend to have, which includes malnutrition, HIV, silicosis, diabetes, homelessness, overcrowding, and smoking, could all put them at higher risk of both getting COVID and once they get COVID, have a poorer outcome. Now, of these, some are confirmed, like diabetes, we know definitely increases the risk of fatality with COVID. Others, there's very little data at this point. But again, I would not rule these out at this point without data. I think it's safer to argue that these comorbidities will increase the risk of COVID or fatality after COVID. This we know is already happening. Diversion of healthcare workforce and resources absolutely is happening, and you will hear it in a second from colleagues in China and Korea. Even in Montreal, all non-essential services have been canceled. Unless it's a critical emergency, nobody is getting anything done here. So which means even the routine TB clinic services here are being impacted. And this is happening in Montreal. I can't imagine it not happening in settings with even worse COVID numbers. The other thing we are hearing is that healthcare workers are anxious about seeing patients with cough and fever because many of them currently lack personal protective equipment. So if they don't have respirators, they don't have adequate confidence in TB infection control, they don't know who has COVID, they don't know who has tuberculosis, and they might be anxious to see anyone with respiratory symptoms. We already know from places like Korea that negative pressure isolation rooms and MDR wards have been taken over to treat COVID patients. So the loss in the hospital beds in TB is a very real concern. We also know about disruption of diagnostic services. Pretty much every lab anywhere in the world is now flat out running COVID tests. And even with them going flat out, they're not even meeting a bare a proportion of the real need. In fact, academic labs are being recruited to run COVID tests. PhD students are being called to help out with running COVID tests. I cannot not see any lab that will not be prioritized for COVID ahead of TB, which means routine TB testing, drug susceptibility testing numbers will fall is my prediction. Now, we know that just a few days ago, a cartridge for a gene expert for COVID testing got approved by FDA as an emergency use license. But we could interpret that as great news, or we could interpret that as the news that could also raise some concerns. The good news of that would be the same gene expert machine that we already have for TB in many, many countries can now run both COVID and MTB RIF cartridges on the same machine, which is great. We want access to both tests right now. But there is also a risk that because the COVID testing demand will be so great that TB cartridges will be deprioritized and COVID tests is all the expert machine will be running. Now, is that happening? I don't know yet because the company hasn't even shipped out the first batch of kits to anybody yet. If at all they ship to anyone, it will probably go to American hospitals over any other country. Secondly, if the demand on the COVID test is extraordinarily high, which it is, even within America, will Cepheid deprioritize their production system for the MTB RIF cartridge at the cost of scaling up production of the expert SARS-CoV cartridge? I don't have any data to say that that'll happen, but I think we would be remiss in not anticipating this collateral damage, because if the production lines are fixed, the capacity is fixed for them to produce cartridges, they will prioritize COVID cartridge over expert cartridge, because I'm 100% sure the COVID cartridge will bring them greater profits than the expert MTB RIF cartridge, which brings them the least profit. So this is a simple business logic, and Cepheid is a corporate company based in the US. That is my hunch. I would love to be proven wrong, but there is nothing that reassures me that expert production for TB will not come at the cost of COVID cartridge. And all of this might substantially delay diagnosis of TB, and we know what that means in terms of transmission risks. Next, fall in TB notifications are already happening and will continue to happen. This exactly is what happened during the SARS outbreak. During the SARS outbreak, there is clear data that routine TB notifications dropped. And that's partly because patients are likely to defer care seeking. If patients are in a lockdown mode and discouraged from going outside, and if they have cough, a new TB patient will not go and seek care. And already TB is diagnosed after 2 months of delay. And this means diagnostic delay will be even worse, and this will result in a drop in TB notifications. And if a routine follow-up, adherence counseling, patient support suffers, then we're going to see many more people interrupting TB treatment. And of all the forms of TB, my anxiety is greatest for DRTB, just because DRTB is already so complicated to treat. DRTB is already a long treatment. The chances of DRTB getting disrupted is the highest in my opinion. And then other things like contact investigation, active case finding, preventive therapy are probably all going to fall off a cliff because these will not be considered high priority within any TB system. The biggest priority will go for active TB. Everything else is likely to be deprioritized in an emergency situation. Supply chain. I was so sad to see this article today, actually, by Disha Shetty in India Sven, that COVID-19 could disrupt TB drug supply, hitting the most vulnerable people. I was hoping against hope that this is not true, but I will not be shocked at all with the disruption in the TB drug supply chain, partly because China is the biggest supplier of the active pharmaceutical ingredients, including those that Indian generic companies will need to buy. So a disruption in the drug supply chain is probably coming our way. Disruption in supply chain for medicines and tests like Expert, we need to worry about. And we already know N95 respirator and masks are like gold dust right now. Nobody has enough supply, even in the richest parts of the world. These respirator masks are at premium. Diversion of funding, I've not heard about any real reports as of this point, but my concern is more in the longer term. In the shorter term, it's quite possible that some of the TB budget might go into fighting COVID, but the longer term is the massive multiple trillion economic loss that the world is currently enduring. And whether that could be used as a rationale for scaling back on TB investments. So just imagine the next global. Petra, am I on?
Yeah, keep going, Madhu.
Yeah. So imagine the next global fund replenishment, where the US, for example, having suffered immense losses, will replenish global fund anywhere close to what they did this year, or funding for USAID's TB program. What will UK contribute? What will Canada contribute? I have no idea. And I think it will be, again, we would be remiss in not anticipating a big drop in TB funding in the coming years, because the whole world will be recovering from the devastation of the economic losses. And disruption of social benefits. Even currently, we know direct benefits in countries like India, cash transfers to TB patients, are not happening anywhere at the rate they should be happening. And this was not happening even before COVID. And now with the colossal COVID-related shutdowns, people working at home, people not going to the bank, people not being able to encash their money or even go up with all the documentation required, we have no idea how badly social benefit and cash benefits will get disrupted by COVID. TB research, what can we say? All TB conferences are canceled. I simply cannot see us going to the Union conference this year. Maybe it will happen, maybe it won't. Every one of us canceled our World TB Day events. Everything is moved online. All research has ground to a halt. Nobody here is able to go to their TB labs and do basic science research anymore. I'm sure all clinical trial recruitments will grind to a halt. All vaccine trial recruitments will grind to a halt. And policy making will get pushed back. WHO is running 24/7 on COVID. So I don't know what WHO's capacity is to look at new TB guidelines or updating existing TB guidelines. And with all the massive millions spent now on COVID tests, COVID drugs, and COVID vaccine, could we see even a lower investment in TB R&D for the new tools that we need. We already know we are a billion short of what we need for TB R&D, and could that gap worsen? And then lastly, what would the TB data coming in look like with the kind of disruption we are seeing? Will we see much weaker cohort data because we're simply not able to talk to the same patients anymore? We're not able to follow them up anymore. Will our numbers suffer because people are not even showing up in health systems? I don't know how this is going to look like, but I expect a certain disruption of TB data systems. Now, coming to the last segment, which is what we are here for, how do we mitigate this damage? So we assume there's going to be damage, a fair bit of damage, but if we worked hard, could we at least prevent it from reaching catastrophic proportions is the correct question to ask. And I'm happy to see that we have different agencies already getting anxious about it and brainstorming about it. WHO a few days ago put out an information note on TB and COVID. UNAIDS has done the exact same thing for HIV and COVID. These major programs, TB and HIV, are supremely concerned about what is happening and should be on top of it. In my Forbes piece, I suggested that we need a damage control plan explicitly, and we need a central damage control unit, one that is trans-country, which involves all major agencies and players. That should be like a war room to prevent TB-related damage. And as we started off by saying, if we are not proactive, we're going to see massive setbacks in everything that we've gained in TB. I just don't see us ending TB by 2030 if we don't do something drastic right now. Now, coming to a few concrete suggestions. So the Stop TB Partnership for today's TB Day has already put out some critical key messages. For example, Stop TB says, we must recognize that people with TB are vulnerable to COVID-19, right? So we're already declaring that anyone with TB or has survived TB are at high risk and should be protected at all costs. The WHO note says that TB patients should take precautions as advised by the local health authorities to be protected from COVID and continue the TB treatment as prescribed. But I am yet to see a very clear message as to whether we should all advocate for anyone currently with TB or has survived TB to self-isolate. But of course, if the whole country is self-isolating, then it's a done deal, it's a given. But if that is not happening, should there be a clear message that anyone with TB or has survived TB must try and self-isolate themselves as much as possible? Now, is this even a practical recommendation? In a country like India or in a township in South Africa, that there are so many people crowded together, is this a completely nonsensical recommendation to make? While what might work in US or Canada probably is completely not feasible in some countries. But I'm putting it out there for us to discuss whether we should really be advocating for anyone with TB to isolate themselves. Or at a minimum, should we advocate them for to be prioritized for COVID testing? So here is a realistic scenario. Let's say I have TB or I've survived TB, and now I have some symptoms. Now, do I know whether my symptoms are because of TB or is it COVID? And how would I know if I don't get tested? Now, currently in most countries, the testing criteria are so rigid that you cannot get a COVID test, even if you wanted it. Should we all advocate that if you have a history of TB, if you currently have TB, and if you have any COVID-like symptoms, you should be at the top of the pile for COVID testing? Could that be some practical advocacy message that we could work on? Okay. And then the last slide is a few other suggestions I like to put out there for discussion. And then we will continue populating the slide deck as this conversation unfolds, because there'll be many suggestions coming from you. Some of us, including those few people on the phone, are already thinking of launching a TB service disruption tracker. The idea being, can we crowdsource intelligence on what sorts of disruptions are happening in which health facility, in which county, district, village, so that we can escalate it to the right authority to actively mitigate the disruption. Disruption, for example, could be the routine TB clinic is shut, or I'm not getting an appointment for 4 months. My drug refill is not happening on time. I'm being discharged from my TB bed much earlier than I was told, or I'm not able to simply talk to anybody in the TB clinic. There are clear-cut service disruptions that are likely to happen, and we could crowdsource and track them so that we can take it to the NPP manager, we could take it to the district health authority, we could take it to the hospital and say, hey guys, you're completely failing on meeting the needs of your TB patients. We might need to think about task shifting and recruitment of volunteers if the TB care system is entirely taken over by COVID-19. If all the TB staff, people who should be looking after TB, are suddenly asked to go and do COVID work, and could we find somebody else to take up that slack? For all new patients who are diagnosed right now, could we advocate for giving them 6 months of drug supply at one go, with the assumption that we may not see them for a while, and therefore asking them to come back every month may simply not work. So give them the complete drug supply at start, and then continue to follow them up through remote consultations, such as call centers, peer-to-peer counseling, link them with another TB survivor, a digital adherence tool like Video DOT, 99 Dots, any other smart pill box. Find a way to provide some online remote consultation help after the initial drug supply is given to them. Could we outsource lab testing to private or academic or NGO centers if the entire public system is completely taken over by COVID testing? There are a bunch of public-private mixed projects that are ongoing in many countries. And if the public health system is completely overwhelmed with COVID, could we get more private providers to step in and pick up the slack and ensure that continuity of care is done? And could we have these interface agencies play a bigger role during this crisis to make sure patients are not? As far as payments are concerned, this would be a great time to try automated payment systems to make sure regular cash benefits are flowing to TB patients. And then I wish we had a fantastic point of care TB test option that could step in even if the lab services are disrupted. At this point, we have the urine lamp test, which could be used more aggressively. There are more closer to patient solutions like the MolBio test for TB. So if the gene expert supply chain is disrupted, we could think of alternative molecular tests like LAM and MolBio to pick up the slack until we have a truly point of care solution for TB. And I will keep updating this mitigation strategies based on our conversation that unfolds. So Petra, I'll now hand back to you. You can mute me and then you can invite the next speaker.
Thank you, Madhu. That's very great. Thank you for an excellent presentation. I'm having many questions pop in right now already. I would like to ask Hairong, would you like to comment from China on and add some of your details from on the ground, please? Hairong, are you there?
Okay. Can you hear me?
Yes, please go ahead, Hairong.
Oh, yeah. Okay. Hello, everyone. Sorry for my video. And this is Hairong from Beijing Trust Hospital, China. And our hospital is a national level TB designated hospital in China. And I am a microbiologist working in the National TB Clinical Laboratory. I thank Dr. Madhu and other organizers for giving me this chance to talk about the coronavirus epidemic and its impact on TB patient care in China. So firstly, I'd like to give a brief introduction on the COVID epidemiological status in China now. Since China announced the whole nation emergency on January 23rd, a lot of efforts had been made. And now the pandemic seems well controlled in China, and the total case number dropped from more than 80,000 to about 4,000 cases now. So we almost have no new case in the last week around the country, even in Wuhan city, where is the core of this outburst in China. And many provinces now have cleared of the disease, which means they have 0 case. In the past week, all the new reported patient was imported cases. So the key point for coronavirus control in China switched from stopping the community transmission to identifying every imported case now. And now Chinese custom has become the main battlefield. Based on the experience of China on coronavirus control in the past 2 weeks, I think that quarantine, no party, no conference, and temporary having hospitals are effective measures for disease control. Secondly, I'd like to talk about the impact of this COVID on TB patient care. So this pandemic is definitely having negative impacts on TB community. In cities with heavy burden of COVID, the hospitals was overwhelmed by the large number of this virus patient. So the top priority was treating this patient, and all the clinicians, no matter in which areas, participate in COVID patient care. Some hospitals had to discharge many patients with other disease to give birth to a COVID patient. Hospitals have no capacity to treat other patients, including TB. Additionally, since long distance travel was prohibited in some areas of China, patients
Sorry about that. I'm trying to find Hairong again. If people can please keep their microphones muted, that would be great. I don't know why people keep turning them on. Hairong, please continue. Hairong, please continue.
Okay. The hospitals in China, they will investigate all patients for possible COVID infection before any further activity in the last 2 months. So the laboratory testing of TB could also be interrupted. However, in spite of all the above negative impact, I presume that there might also be some positive impact on TB, because the quarantine might also limited the TB transmission to some extent, except it was bad for the family member. In the past 2 months, a lot of Chinese doctors provided consultation on internet, including TB doctor. My colleagues in Beijing Trust Hospital post videos on internet for TB patients to guide them to deal with different conditions in the context of this pandemic. Besides that, many volunteers helped patients to prescribe anti-TB drug and send them by mail. Chinese health provider took actions to reduce the possibility of TB treatment interruption, although we know it was far enough. Now, I'm glad to see that TB patient care is back on track gradually in China. I called colleagues in Wuhan city today, and they said that the hospitals we hospitalized more and more TB patients since last week. So I believe that the majority part of China will resume their routine lives and routine works very soon. According to the cause of the coronavirus control in China, we can see that the sooner we can control the virus, the less damage it might cause on the TB community. So that's all I like to say. Thanks.
Thank you very much, Hairong. These are really important points to consider. I would like to call on JJ from South Korea. JJ, can you please take over from me?
Okay. Thank you.
Can everyone else please keep their stuff muted?
Hi, I'm JJ Im, a pulmonary physician working at Seoul National University Hospital in Seoul, South Korea. So care for a TB patient is being marginalized due to COVID-19 epidemic in our country. I'd like to tell you about 3 aspects. First of all, we cannot admit TB patient anymore. We have originally 8 negative pressure single occupant rooms for TB patient. Usually 5 or 6 TB patients are admitted. But in fact, South Korea requires at least 2-week hospitalization for MDR TB patient by law. But because of COVID-19 epidemic, all but 1 TB patient were discharged. And now we are not able to admit any new MDR TB patient or patient who have been referred to our hospital. The second aspect is outpatient care. It became difficult for TB patients to visit outpatient clinic as scheduled. One of my ex-DR TB patients missed her visit last week. TB nurse in our institution contacted her immediately, and she said, because the schools are closed, I should take care of my 2 children at home, so I could not visit the clinic. And some patients miss their scheduled clinic visit for the fear of in-hospital transmission of COVID-19. Regardless of scientific evidence, the TB patient believes that they are high-risk group for COVID-19 infection. And last one is, we are running out of N95 respirators. We still have some, but one of my colleagues working in another university-affiliated hospital told me that N95 respirators are running almost out of the stock. So healthcare professionals wear surgical or dental mask when they are taking care of a TB patient. In that hospital, only clinicians who take care of a COVID-19 patient can use N95 respirators in that hospital. So let me summarize. In South Korea, the treatment for TB patients are being hampered by COVID-19 epidemic in terms of inpatient care, outpatient care, and redirected resources. Thank you.
Thank you very much, JJ. That's really important to hear your immediate responses and your immediate points from South Korea. And the situation in South Korea is going to be really important to look at. We would like to now hear from Vidya Krishnan. Vidya, would you like to take over?
Can you hear me?
Yes, please go ahead.
Hi, everyone. It's really nice to see people who understand the urgency of the situation we are in. I'm afraid I don't have great news from India. I did not have the time to make a presentation because I have been reporting almost for 2 weeks nonstop. So I'm just gonna read out from my reporting notes and tell you what's happening. As of today, we have crossed around 500 cases and 10 people have died. According to the government, like Madhu said earlier, the government is testing next to nil. And essentially, every worst case scenario that I imagined has come together in this particular case. We do not have testing kits. I've been reporting about this, how India did not stockpile in the 2 months when WHO had issued those guidelines that there is going to be disruption to supply chains. And because it did not ban export of material, the domestic manufacturers kept exporting it to countries that were stockpiling. And just as there is a surge in cases now, we are finding out that not only do we have a health system that is not prepared, we are armed with nothing. Our doctors don't have PPE kits. There is, we are short of testing kits. We do not have ventilators, and we do not have doctors or nurses. And I'm sorry, it's just been very grim 2 weeks in India. And one of the bigger challenges that's emerged is that the government at this point tends to be taking political decisions than decisions that are prioritizing national health. And one of the things that's happening because of that is we don't know the exact extent of damage, because the government is denying consistently that even as of yesterday, the ICMR has said that there is no community transmission in India. And with the government saying there's no community transmission, it's just getting more and more difficult to make sure that we are prepared for what's coming in the next few weeks. Epidemiologists are saying there's going to be a tsunami of cases. And there is a big, like always, there is a pandemic and there is extreme social fracture. Today, there were cases where doctors were beaten up because in some cases, their landlords said that they are spreading infection when they come from the hospital. And there was this surgeon who went back home after a long shift and found out that he'd been evicted behind his back. So there is that kind of social fracture that's already showing up. There was a man who was lynched the other day. He didn't die, but he was beaten up for sneezing without covering his mouth. So we went from completely not caring about cuffing etiquette to just going to the extreme extent. And a lot of that is fueled by the political situation in India right now. I've been in touch with WHO, which is very closely following the misinformation that has come along with this particular pandemic. And there was a New York Times report which said that a lot of misinformation that's going around in the English-speaking world is actually originating in Hindi and Hebrew. And again, a lot of this misinformation is being peddled by political leaders. So I'm really worried about how the government is responding at this point. The second issue that I'm very concerned about is that as against every other country which has made testing free just to understand the extent of what is going on, the community transmission, India has priced the testing kit at, India has outsourced it to private laboratories, and they haven't price capped it, and it's going, a testing kit, it costs around $60, which no one in India can afford. And one of the concerns I am already getting reports is today labs have started testing people at $60. And what's happening in countries like India is that this disease is bringing the caste and class divide in the society. So anyone who's rich and has $60 to spare is getting themselves tested, whether they require that or not. And people who might possibly be infected do not have the money to get tested, and they may never get factored in the statistics when I don't even know when dust settles, but even speaking theoretically about that, the other big concern is that the Indian government has handed the monopoly of private manufacturing kits to one particular company. And the monopoly is delaying and has created a bottleneck in supply of PPE kits. And the manufacturer association, the companies that manufacture PPE kits, are saying that they will walk out and they will not supply and they will go on a strike, which is what I'm very concerned about. The other concern is I broke a story about how the last 2 months India had not stockpiled. And one of the ripple effects of that story, which I regret at this point, has been that resident doctors across medical colleges are considering going on strike. And again, this is not something, these are conversations that are just going on, and I get to hear about them as a reporter, but everything else is crumbling. Now, coming back to the impact on TB, even just as a base assumption, everything has come to a grinding halt at this point. The TB patients are not getting the care they need. Everything is in fact, not only is everything in lockdown, people who are moving garments that are required. Yesterday, a PPE kit manufacturer told me that he's not able to move his product to the hospital because the police doesn't understand that this is an essential commodity. So the amount of information the community has is actually a massive hamstring to the response the government has.
Vidya, we can't hear you anymore. Keep going.
Can you hear me now?
Now we can hear you, yes.
So there are two concerns I have now, speaking strictly as a journalist at this point. I've been trying to reach out to global voices to get them at WHO and multiple agencies to see if they can comment on what are the good practices. Is it better that countries with weaker health systems make testing and treatment free, which at this point is critical in a country like India. There is no way we will make it past if we do not make testing universal. I understand there is a decision on asymptomatic testing for COVID cases, which is to be taken in a day or two. Again, the government is not very forthcoming with the kind of decisions they're taking. So everything that is being reported is based on a leak from the ministry or from well-meaning people in the healthcare worker system, within the health system. And one of the dead ends that I have is there are no global voices. Everyone is busy in their regional areas, that no one is standing up and speaking for nations. This is true for African nations as well as poorer Asian nations, where testing will have to be made free. And this is, unless there is international political pressure, I do not see why the Indian government will give in to that. And the other aspect that I completely missed to say is India is also home to we have this geographical misfortune of being right under the shadow of the Himalayan mountain range. So entire North India has the worst air pollution because the mountain range stops the air flow. And between the COPD from bad quality of air and the highest burden of TB, I've been told by an epidemiologist in India that we should expect a carnage, and I am very worried and very anxious. I'm gonna wrap it up at that. I'm sorry I did not come with any good news at this point.
No, that's totally, Vidya. Thank you. Your personal concerns and your stories are just really showing us how important it is that we increase the alarm bells, that we ring the alarm bells about this issue. And I really thank you for bringing forward these very visual images of concern. I think one thing that we all can do is ensure that issues of stigma and social pressures, that we spread the right information. I would, in following on your story, I think it is very timely that we ask some of the TB survivors to bring forward their concerns and their suggestions, having been in this exact position. So can I please ask Ingrid Schoeman from South Africa to speak first?
Hello. Drug-resistant TB nearly killed me. I developed liver failure and I went into a coma. So I was in hospital for 75 days. And in that time, I felt like giving up despite having good social support and also having economic resources. This opened my eyes to this immense suffering caused by TB. And now across the world, like we just told us, people are seeing the impact of infectious diseases like TB and COVID-19, and it's hurting those that are most vulnerable. I'm proud that our president announced a lockdown on the 15th of March to protect South Africans from transmission. However, the laws, regulation, and basic information about COVID-19 is not always filtered down to community level. I am struck by the compassion and the commitment of our community health workers in this time. They want to protect and they want to inform their communities. They're still at the front line providing healthcare services and trying to find people with TB and to link them with healthcare, making me realize that we can't end TB without community health workers. Over the past years, TB Proof has moved towards supporting community health workers, both as TB champions, but also now as trusted sources of COVID-19 information within their local community. We've recently developed a broader TB Proof initiative to respond to the new global COVID-19 pandemic by relying on our strength because we are an advocacy organization. So I would like to share that with you. Firstly, TB Proof members were part of a team that led a petition, Lock South Africa Down. And this was supported by 30,000 people who signed on, and we were able to share the petition with the Department of Health prior to the President's announcement to Lock South Africa Down. Then secondly, it's been very valuable because we have public health experts among our group of volunteers, and they use their expertise and their access to the latest scientific information to share that with us and our networks. And also they are engaging with the media so that we're trying to reach a diversity in our affected communities. And finally, I'm passionate about community health workers, as you can notice. And we've started a WhatsApp group with them, and we've provided free internet access or data bundles. So on the group, we share information from the Department of Health, sources from WHO, and also TB Proof summaries like our recent TB activist guide on coronavirus. Community health workers are able to ask us questions and receive answers rapidly, equipping them with knowledge to respond locally. As a TB survivor and activist, along with all of you on the call today, I'm acutely aware of the 4,000 deaths due to TB every day. With the COVID-19 outbreak, increased strain on our health services, drug supplies, shortages of key equipment for TB prevention, I'm calling on my fellow TB activists here that we can all share what we have learned about infectious disease through our work on TB, and to use our platforms and networks to call for a comprehensive science-based TB response to COVID-19 pandemic in each and every country in the world. We shouldn't be afraid to talk about TB using every opportunity that we are still getting. But now more than ever, we need to unite and we need to envision the highest attainable standard of health for each of our communities where we are living. And the only way to get there is for each person to take responsibility for our collective health as human beings. Thank you.
Thank you, Ingrid. I would like to ask Deepti to start saying a few words from India.
Hello everyone. We all are very anxious about COVID-19, but I am a bit biased towards TB. You know, more often than not, I find people going and checking on the dashboards every day and, you know, panicking on every single death that is happening due to COVID-19 and panicking over every new case that has been diagnosed. TB kills millions every year, and I don't see the same amount of panic for that. Forget panic, I don't even see people caring enough about it. Like Madhu sir said, that there is going to be disruption of TB services, and since many cities in India are on lockdown, more and more patients are finding it difficult to go to the health center to collect their medicines. So it's extremely difficult, and we are getting calls from TB patients who are very anxious, and then they really don't know you know, what they can do about the treatment and who should they contact, and there is no helpline for COVID and TB per se. So can we develop a mechanism where we can actually deliver the medicines to the patients instead of asking them to come to the healthcare facility? Because as we have already established, that people who are diagnosed with TB or are suffering with TB are high risk patients, so to say, and it's very likely that they will catch the infection and may not survive it. And just as there is a helpline where we inform them about the symptoms, if you're having any COVID-19 symptoms, people come to your houses and take your sample. Can we establish similar measures for TB patients who are currently on facing are showing symptoms of TB? Also, just because there is a pandemic going, it's not that people are going to stop getting infected with TB. So we cannot really ignore TB at this point, because once this is all over, we are only going to find out that TB has really I'm really sorry, but I do not want to use this word, but TB is going to really take a toll, and the numbers are only going to rise if we do not pay attention to those who are affected with TB now.
Deepti, thank you very much. You hit the hammer on the nail in many aspects. I would like to ask Kate to from the US to give your points and your perspective, please.
Okay, can you guys hear me?
Yes, very clearly.
Great, excellent. So yeah, I'm just gonna kind of back up on things that a lot of people already said. TB survivors are definitely worried. When I talk to other people in We Are TB, which is like a United States-based TB survivor organization, we're more likely to have the lung damage. And in the United States, like there's this real push to like stay home, but there isn't like a nationwide rent relief. There's no sick days. A lot of people don't have health insurance. So I think it's really unrealistic now to ask people to go to work. I think it's coming from this credible point of privilege. So it's just not really the only real advice anyone's getting is to stay home. And that just really doesn't work for a lot of people who might be at risk for tuberculosis, especially. Right now in the United States, TB staff and their expertise, it's all being diverted to address COVID. And TB units and TB patients, they're being like reassigned to other beds, or they're being discharged early. They're not being seen in clinic as much as possible. They're getting VDOT instead of regular DOT. And when you have tuberculosis, like, you know, like I did, and you take these medications, like these side effects are rough and they really need to be monitored. Even if as we start to move away from injectables or some of these other medications that are difficult on patients, like even the baseline tuberculosis medications that almost everybody takes, you know, have liver problems, and you know, they should be getting their blood tested and all these other things. It's like, where does that kind of get addressed? And And when we're having the staffing issues that we're having, we're not having the thorough kind of contact investigations that we need, because that requires resources. But if everyone's staying home and we haven't thoroughly investigated contacts, like that's a risk of transmitting the disease. So I think a lot of people in the United States right now are kind of realizing maybe that it's not great that we don't have any kind of social safety net. We don't have any paid sick days. We don't have any of these things that other countries seem to have. So hopefully people wake up, because we have to ensure a robust, sustained public health infrastructure always, not just when we have some sort of a crisis, not just funded by these like surge appropriations we get to address a pandemic, but maybe we have to change our system so that it's more fair and equitable, and that it works, like, just that it works, because right now it's not working. If there are anybody here who votes in the United States, right now, we're pushing for our legislators for two pieces of legislation. You can ask your representatives about the End TB Now Act, and you can also ask them about the Comprehensive TB Elimination Act. And you can also ask me about those things. And I'm happy to tell you about it if you vote in the United States.
Okay, thank you very much. Saurabh, I've kept you waiting with your provocative t-shirt so that everyone can view it. So that's why I would like to give you the word last. Please go ahead.
Well, am I audible?
Yes. Okay,
perfect. Well, I'm super anxious about what's going on in India, and Vidya just, said everything rightly. As a drug-resistant TB survivor, we've always had to make tough choices, and COVID hasn't really helped on that front. Even now, I'm supposed to be a high-risk patient, and my city is on lockdown. Mumbai, the most densely populated city around here, it's on lockdown. We can get groceries maybe once in 2 days. I'm still lucky I can afford groceries. I can go out, get them. Other TB survivors who come from a background that they can't afford to buy food are really stuck. Forget medicines, just getting the right food right now is a big problem for them. Another thing is the tough choice, right? Anyone who's above a certain age is also high risk. So my parents are high risk. Now I'm supposed to choose between, should I send my parents out to buy groceries or should I go and buy groceries? I don't know how that's fair in any sense, but that's how it is. And I just can't imagine what people who live like 13 people in a house, 14 people in a house, there's no concept of quarantine for them. There's no concept of distancing for them. And that's my entire city. That's how Mumbai is. And forget that, as a survivor, what I'm going through, it's the patients who are reaching out to us. They are being sent away. They don't know where to go. The lines of communications have become very weak because since it's a curfew, not more than 4 people can be seen together on the road. Section 144 has been put into place. Just getting out, talking to someone else has become very challenging. I am firmly of the belief that, everyone's using WhatsApp now, and we've started like this group where we are helping patients get services, one-on-one basis, or add them to some groups where they get answers. Even then, there are a chunk of patients who don't have access to cell phones. How do we reach them? How do we solve problems for them? And how do we communicate with them to understand, what services they need? How can we sort of help them out in these tough times? India has the highest number of TB cases. That's after under-testing for TB. We're not testing enough for COVID. So I'm scared about what's going to happen in the next coming 2 or 3 months, or maybe even 1 month. What kind of blast are we expecting? And that's going to hit TB very, very badly. We just don't have enough manpower to take care of it right now. My batchmates, I'm a doctor, and my batchmates keep texting me saying, they're calling on interns, first year, second years to come collect blood, help them take swabs and like do testing. And I can't go, even if I'm qualified to go, I can't go. And that's, it kind of kills you on the inside where you're qualified to help, but you can't help. So personally, I think these are the challenges I'm facing, and COVID is making me very restless on the inside, but I'm also very worried about how the system is not ready to tackle problems, or I don't think they are even thinking about TB in any way right now. It's not on their radar. It's nowhere near. And like Deepti rightly pointed out, right, I have a biased TB. I feel like, this TB hasn't been given the attention that COVID is getting. And if you can hire the COVID PR team, we should totally do that. At the same time, I also believe that, we are standing together strong, helping fight the pandemic, but my fear still stays that TB is sort of going to take a hit.
Saurabh, thank you. All four of you, thank you very much for stressing the anxiety, the worries, and putting really the urgency of a response forward in really poignant words. I would like to ask Sahu Suvanand from the Stop TB Partnership to say a few words. Sahu, please.
Hi, everyone. Good morning, good afternoon, or good evening, depending on where you are. Who would have thought that on a World TB Day, more than 300 people on a virtual network, not meetings, not events. So this is completely unprecedented, but we also must respond in an unprecedented way. As you saw from the Stop TB partnership, we modified the messages for World TB Day. In fact, today we held 3 virtual town halls, each one with about 100 people connected for different regions of the world. I think the last one must be still going on. So it is great to see that people are shifting to the digital and virtual platform. I completely agree with what Madhu suggested. And I will say a few things and maybe add a few things to what Madhu already has in his list. So one of the things that we realized with a lot of feedback and we are going to do immediately is to help countries, partners, people to shift into a virtual mode of TB, both program management as well as patient care. I think it is very clear from different people talking here how TB programs have been disrupted. The only way to limit the damage is to shift into a virtual mode when people are starting to work from home. We envisage that almost every country will go through a lockdown phase. The leaders are talking about 1 week, 2 weeks, 3 weeks at a time. But from the experience of China and other countries, we feel that it could be 2 to 3 months. So we should be prepared to shift the TB activities to a virtual mode. So for this, we have quickly moved and we have compiled a note which has compiled all the digital tools that are available for program management, training, patient care, telemedicine, digital tools for diagnosis, digital adherence tools for treatment. All of them we are trying to compile into a note which should be available on our website, hopefully tomorrow. And we'll send a news alert about it. We feel that this will give countries some ideas and help about how to make things virtual. This will have also links to those technologies and how you can get support to implement them in your local setting. So that is something that that should go out. Some of you may also have the experience of using the One Impact app that Stop TB was working with. It was used only in a few countries, but now we feel that that kind of app or any modifications therein can help many more people to virtually connect both patients as well as frontline workers. So we will tweak the One Impact app and also put out some things on the website on how to use it. And we are also collecting some information in the form of a survey through that app, as well as a website which will be devoted for this. So that's about the digital part of it. Let me talk about the drugs, diagnostics, and other measures that people talked about here and what we are trying to also do. We must all realize that experience is very limited here, but we are trying to see what can be done. We were very encouraged by a few countries who put out some letters instructing their TB programs what to do and how to respond. And we are planning to share all of those letters on this TB and COVID web page that we are designing today and should be up, hopefully running tomorrow onwards. We saw a number of things, and let me just talk about a few of them here. First of all, drugs. So as Madhu put there, to give drugs to the people having TB, we fully support that. This is not just 1 week or 2 weeks of lockdown. This will be multiple months. So we will be pushing for multiple months of drug supply to be made available at the home of people taking TB treatment, both TB as well as drug-resistant TB. We realize one issue here that if we prescribe a longer duration of drugs to be given away, the central stores of TB program may run dry. So new patients may not have drugs to be given to them. So I think some local discretion is needed in a planning which will keep a balance between what is needed at home to get over a situation, hopefully 2 to 3 months, versus what is needed in the stores for new patients to start treatment. We are also advising, and Global Fund is advising to their principal recipient to plan procurement early. I think people talked about drug shortages. We are aware that India, the situation is getting worse now. The TB drugs, active ingredients are manufactured mostly in China, but most of the products are manufactured in India. So we are keeping a close eye on what is happening in India, especially from the Global Drug Facility perspective, which is housed in the Stop TB partnership. We are keeping track of what is happening. So far, the main concern has been under a lockdown condition. How do you move stocks from the manufacturing unit to the ports to be supplied to outside the country, but also inside India? So procurement and early planning is very important. Also planning the downstream supply of drugs to the people on treatment is very important. Despite lockdown, how to reach them with treatment. We should also plan in such a way that people are not asked to come repeatedly to the health system. And we saw that some countries have also issued notification on this. One clear thing that I think we should do, and I'm suggesting Madhu to also add there, is for drug-resistant TB treatment, we immediately shift countries should immediately shift people to all oral and preferably the short regimen. That will be beneficial in terms of not asking people to come for injections and also getting the treatment over in a shorter period of time than longer period. We also need to think about how to monitor adverse events remotely, virtually, and I think a lot of innovations will come in that, and we must follow up on that. Then let me talk about diagnostics. The message that is going on in places where people have been locked down is stay home. Don't come to the healthcare setting. Even if you have cough and fever, monitor yourself, and you get tested only when you fulfill certain conditions. This is something that we feel could also delay the TB diagnosis. We need to think about some messaging which can help not to go against what is being said for isolation and for the COVID outbreak, but also think about how we can follow through on people who have cough and fever, who ultimately are found not to have COVID after the quarantine period or after the test. How do we follow that up and do a TB test? I think this remains a challenge. People have talked about labs being preoccupied with COVID, not enough bandwidth to do TB. And let me also add that the Gene Expert cartridge that got launched today, Philippe Jacon from CIFID was on one of the town halls, that virtual town hall that we did, and he did say that the tests will be available for high burden, low income settings. And we did discuss about how it should be used. We also should be careful that while countries order these test cartridges, they should order more machines as well, because the TB machines are limited. And this is an opportunity to get all health facilities equipped with more Gene Expert machines. We're also aware that 180 test platforms are available. Find the website at least has those numbers there. Some are in the pipeline, but many are in the market. There are concerns about testing. But once it is scaled up, we should also think about how do we test for TB in this situation. Let me also talk a little bit about what Madhu said about TB patients being people with TB being vulnerable to COVID. I think we have said that very clearly in our messages, and we will say that further. We need to also act and think about how we can communicate a messaging on what Madhu was saying about how people with TB can isolate themselves, which is a kind of not because of them getting COVID, but it is a kind of reverse quarantine. We got some feedback how the word isolation is viewed sometimes with stigma. So we need to find a way what we call it and how do we do that. But that is very important to protect people with TB from the COVID epidemic. One other thing that I will also mention is about the funding. I think some people talked about it. Global Fund a few days ago has put up a note on how existing grants and the money available in existing grants can be used for COVID-related activities. Global Fund also put out quickly a news alert that 11 countries had approached them and they have approved it. And I'm told the approval process is very quick, 1 to 2 days. We need to think about how other countries can use this mechanism. We are also aware that countries are currently submitting proposals for the next funding cycle to Global Fund. They have been affected. The first round of submission was 23rd of March. Some proposals did come in. The Global Fund is giving some flexibility to complete the process of submission to some of these countries. The next batch is due in the last week of May, and we are in discussion with some countries also for technical assistance, how to support that in a virtual manner rather than in-person missions there. So there are many things to talk about, but I would stop here. But let me just give a bit of hope here that we are, if everything goes according to what we saw in China, we should imagine a post-COVID TB world. We should then imagine a situation where we should have a catch-up, a bounce back, but also not to the same situation as we were before COVID, because the world would have changed. We should think about how we can bounce back and do a catch-up into a world post-COVID, which will be more virtual, different kind of world, more opportunities for connecting people in the community, more opportunities for innovation on the digital tools, and also working outside the health facilities in an ambulatory manner. So look forward to that. Thank you. Thank you for this opportunity.
Sahu, thank you very much. You've touched also on all of the questions that have been asked during the chat. I realize we have very short time left for discussion. I'm going to just mention some of the key headings. We've had some questions with concerns from Africa, especially related to mine workers and children. We've had some questions related to diagnosis, techniques of the NAAT having priority, questions about that, differential diagnosis. We've had some questions about the COVID and the gene expert. We've had some questions on the Global Fund. We've had questions and many suggestions on how DOT can be done differently, or how we can use interactive tools to help in the communication. We've had questions about mental health, anxiety, stress, privacy and confidentiality. So I'm going to put all these questions on our forum. I'm going to cluster them. I'm going to make sure that we will field these questions from different experts to give you answers, and we will put this out widely. At the same time, I thank Sahu for bringing forward what the Stop TB partnership is doing. I think in this situation, we really need to make sure that we are providing information from trusted sources, that what WHO and the Stop TB partnership are putting out is going to be echoed by all of our work. we need to ensure that we're taking misinformation away. So having strong leadership and clear information, we will definitely make sure that we broadcast and we further work on the overall messages that are coming out of WHO and out of Stop TB Partnership. And I would like everyone to also do the same and look at what their national health authorities are putting together on the basis of international guidance. Now, that as a sort of overall message, I would like to ask Madhu to maybe get back to some of the chat responses or some of the presentations that we had, and then I'll try and wrap it up in the end.
Thanks, everyone. That was outstanding. Clearly, as anxious as we are already thinking ahead on how to mitigate the damage. So on my list, which I will add to the slides, and all of you will have access to the slides later today, is a fantastic suggestion, I think, that came from Deepti, that since everybody is on a lockdown mode in most places, could we find a way to contract with a courier company, perhaps, to, if couriers are still working, to have medicines sent to the patients' homes so that they do not have to leave their homes and risk getting exposed in health facilities. A helpline for COVID and TB, I think, is a really nice idea, especially if there is already a TB helpline. Could that be expanded to have people calling in to ask about COVID and TB? The issue that JJ spoke about also resonates a lot with me. Since schools are all closed, and if patients have young children at home, they simply may not be able to go to the health facility for their routine TB follow-ups. So it's all the more important, as Sahu said, to move as much of the consultations digitally as possible. But if patients don't have phones or access to computers or Zoom, I have no idea what that means and how to realistically do this. Digital health is still not universally accessible, and we need to, I think, plan for a solution for people who simply don't have access to phones or internet. The DRTB, encouraging all countries to shift to an all-oral shorter regimen, is aptly should be a done deal. And I think, Sahu, if you can advocate for WHO to send out a communicate to all NTPs to accelerate the switch, I think that would be fantastic. The point that Sahu made, that Global Fund is encouraging use of existing grants for COVID work, honestly, I don't know what to make out of it. Is that a positive, or is that basically a diversion of funding away from TB? If it's new money going into COVID, I could live with it. But if it's going to cannibalize TB funding, which is already scarce, and divert it to COVID, then does that give countries, NTPs, a license to essentially route all the TB monies into COVID, and then what is left for TB? I think this is a time when I think all of us should advocate for new money to go into COVID and not repurposing already scarce TB money. I think that is a clear advocacy message that we should be coming up with. Maybe I misinterpreted what Sahu said, and he can clarify, but I actually got worried when I heard that existing Global Fund grants will be repurposed for COVID, and TB is already a smallest proportion among all Global Fund grants across the three diseases. And then lastly, this is more a question that Sahu can discuss with WHO, or I can write to Teresa. Is there any chance we can advocate for an urgent emergency interim TB report after, say, the first 6 months of this year? I know the TB report really lags behind by a year or so, but if we did an emergency interim data analysis after the first 6 months of this year, we will know exactly what the heck is happening on the ground in terms of a massive drop in notifications or a huge drop in treatment completion. Then armed with that, we can swing into more aggressive damage control. So that's it all from me. I will certainly update the slide deck and make sure Petra posts everything along with the entire webinar recording later today. Thank you.
Thank you, everyone. It's in Ottawa, it's 10:30. It's 1.5 hours. I would like to really express my thanks to all the speakers for putting your heart out here on the screen and stressing the urgency, the panic, and the need for attention to our TB patients, our TB survivors, and countries that are really struggling already with TB programs. Can we harness this urgency and panic, and please help us spread this message on World TB Day today? It's the time where we really need to drive this feeling forward. We stand in solidarity with everyone working on COVID, and at the same time, we are pulled into the COVID response, and yet our regular TB programs will feel the hurt. So I will put everything on the TBPPM forum on our website. We will make it available on Twitter. Please, we will be putting quotes on Twitter. Continue the discussion. I will put each question specifically on our forum. Everyone is encouraged to respond or interact online on any topic that you would like to. I will make sure that if there are expert questions, that I will find the appropriate experts to answer specific questions. So feel free to ask more questions if you have that you have not been able to put forward in this chat. We will continue this debate. It's not going to be over soon. We're in this for the long haul. We need to support each other, and this is the time really to work unitedly. So I will send a quick questionnaire out to everyone who was on this call. Thank you for the 500+ people that have registered to this forum. Thank you for the 350 people that actually were on this call. Thank you for most all of you muting your microphones. That was the only little technical hiccup, but with such a large group, I'm really thankful for your questions, your participation, and your interest. I'm hoping that we will have a follow-up discussion. We're going to be looking at different speakers. So please keep your eyes out this is not a closed discussion. We would like to take this momentum and run with it. Join the town hall at the Stop TB Partnership today. Listen to the WHO webinars that are available, and we will keep you posted on anything that's up there, either through Twitter or through the different mechanisms that we have. With that, I would like to say a last wave and thank you to everyone around the world. Stay strong, stay healthy, and stay safe. And looking forward to seeing everyone again shortly.
Thanks, Petra, and thanks to all the speakers and all of you for participating. We are very grateful. Bye.